So it's my distinct pleasure to introduce Dr. Mishal Mendiratta-Lala from University of Michigan. She is the Director of Abdominal MRI at University of Michigan and also co-director of Interventional Oncology. She does a lot of ablations. She's the first treating physician for the histotripsy Hope for Liver trial and one of the pioneers in histotripsy, which was developed at University of Michigan. She's the chair of the ACR LIRAD's treatment response work group, and she's responsible for all the guidelines development. I work closely with her on a few SAR committees and got a lot of guidance from her. So yeah, she's triple threat person, grants and clinical and education and mentoring and but not like administrative stuff. So Mishal, I believe that's the.
Thank you, Sandeep. Thank you for having me here today. And a special thank you to Sandeep for coordinating it. He's been trying for a while to get me out here, and he did an excellent job coordinating it. So I saw some of you guys this morning. Hopefully you can tolerate one more hour of me today. So I am going to talk to you about an imaging update for LIRAD's treatment response. Now we're at version 2024. We started this pre-COVID at the Hawaii SAR in 2020. And so 4 years later, I think we finally have our final algorithm, which should be up on the ACR website, hopefully within the next few weeks. I have no disclosures other than obviously I'm working very closely with the ACR treatment response working group and SAR working group. So I'm going to kind of give you a brief overview. We're going to start about why local regional therapy and then go into what it is and how do we evaluate liver tumor. So why do we need local regional therapy to the liver? First of all, we know there's an increasing incidence of liver cancer worldwide. It's the 5th most common tumor. Most treatment options are minimally invasive local regional therapies. So whether you're IR or even diagnostic radiology, we really play a vital role in these patients. We treat for curative intent, palliative intent, and then of course, bridging and downstaging for patients to become transplant eligible. There are a multitude of therapies which are currently available for HCC treatment, from surgery, ablations, intraarterial therapies, radiation, and then of course our systemic therapies, our new checkpoint inhibitor therapy as well. So all of these treatment options, how do we know how to treat patients? Well, our treatment recommendations depend on staging. And how do we stage these patients? Oftentimes in radiology, we're not staging them. When you read your MRs and CTs, we just kind of say this is where the tumor is. They're presented at multidisciplinary liver clinic, and there are multiple organizations and staging systems which allow us to stage. BCLC is perhaps the most widely known staging system. It's also the most validated staging system because it looks at prognosis, so your tumor stage, it looks at patient characteristics as well, and it takes into account clinical decision-making in order to come up with a very comprehensive stage. I bring up specifically one of the changes in BCLC for intermediate stage treatment for patients. Historically, there were very limited treatment options for intermediate stage, which was really only TACE. But now with the new update for BCLC, the intermediate stage patients have been grouped into three subgroups. And why is that important for us in radiology? Well, basically, there's been a major expansion in the treatment options for this cohort of patients, which means we're going to be seeing a lot more in terms of treatment from an interventional perspective and treatment response from a diagnostic perspective. So really, that's my point of this slide, is that there's just been a major expansion in the number of patients that are going to be treated with local regional therapies. Now, we treat patients with local regional therapy, what is our impact then, and why do we do it? You know, one of the big reasons obviously is to downstage and bridge them to transplant. But studies have shown that whether or not you get local regional therapy, the 5-year survival is really no difference in those who have and have not had local regional therapy. And in fact, the time to recurrence post-transplant is no difference in those who have and have not had local regional therapy. Furthermore, we do know that the more number of local regional therapies you've had pre-transplant, the earlier and the higher rate of recurrence. So why do we treat HCC with local regional therapy then? Well, AASLD still recommends treating these patients because we want to bridge them to transplant. You don't want them to progress and then be out of the transplant guidelines and then drop from the waiting list because of the increased mortality. And we can downstage patients as well. So again, because ultimately cure for these patients is liver transplant. So now we have talked about patients who need local regional therapy, the different types of local regional therapy that are out there, and how we've decided to, you know, what treatment they get. So how do we look at them after treatment then? So what is our tumor response criteria? First of all, why do we need tumor response criteria? One, it's for standardization after HCC therapy. Remember, many of these patients are going on for transplant, OPTN guidelines. There's national, you know, organizations that look at these patients, which patients are getting organs. So we want to standardize not only the reporting, but the imaging intervals, and tumor response assessment guides clinical management. So do we just continue with our routine clinical routine imaging follow-up? Do they need additional therapy because they have new tumor or residual tumor? And have we downstaged them effectively so that now they are transplant eligible? How do we assess treatment response? So you need contrast enhanced imaging. Historically, we use CT or MRI with extracellular or hepatobiliary agents. Recently, contrast-enhanced ultrasound has been approved for treatment response evaluation. It's very new. It's also kind of hot off the press. I think the algorithm just went up on the ACR website recently. What are our tumor response classification systems then? So we know that there are size-based criteria, right? Think about someone with renal cell cancer, melanoma, lung cancer. We're looking at imaging. Is the size different? Are the tumors getting smaller with treatment? However, with HCC therapy, unfortunately, size-based classification systems don't work after local regional therapy because many times the tumor is still there. It's the same size, but it's devascularized if you've had arterial therapy, or it's necrotic, the coagulation necrosis after thermal ablation. So we needed a new classification system for HCC treatment response assessment. So we have our enhancement-based criteria, where you have MRESIST and EASL, which are size-based. Those are also patient-level classification systems. And then you have LIRADS, which is a relatively new algorithm. It was created in 2017 originally to evaluate at a lesion level the tumor. So how his, you know, if in segment 8, there's an ablation, something that's treated ablation, but in segment 7, it was intra-arterial. Each tumor is characterized separately. So I'm not going to get into all the emerging data, but what we can say is version 2017 provided a single algorithm for all forms of LRT. So I showed you that chart earlier. Imagine one algorithm kind of trying to assess response based on all those treatments. However, our emerging evidence does indicate that non-radiation and radiation-based treatments have different effects on the targeted tumor, which vary over time. And additionally, the use of ancillary features is actually very important for accurately characterizing treatment response. And we're going to get into all of that. So the new algorithm, version 2024, incorporates new knowledge, expert opinion, and user feedback to improve our algorithm and improve the accuracy and sensitivity of the algorithm for detecting viable disease. So if we look at this patient, this is the patient with an LR5 observation pre-TACE. 3 months after TACE, we see excellent devascularization. However, from the 6 to 9 o'clock position, there's a little bit of enhancement post-TACE. So if you use version 2017, Radiologist A said, well, there's enhancement, and so this is viable tumor. Radiologist B said, well, this was treated with intra-arterial therapy, and so this is kind of in the embolic zone, and I think it's probably perfusional. I'm not sure. I'm going to call this equivocal. And radiologist C said, oh no, this is definitely perfusional changes. It was an intra-arterial therapy. I'm going to call it non-viable. So now you have 3 radiologists who've interpreted this differently. This variability in interpretation is in part related to reader confidence, reader experience, and really radiology and pathology, you can't detect viable disease unless you look under a microscope. All right. I'm not going to tell you what this is yet. We'll get into this later in the talk. How about this? So we're using the same algorithm for radiation therapy. And so we've got an LR5 observation treated with SBRT. You see the tumor is smaller. However, it is still enhancing. Radiologist A says it's viable because it's enhancing. Radiologist B says it's enhancing. I'm not sure because it's smaller. So I think maybe it's, the tumor is dying off. Not sure. I'm going to call it equivocal. We'll come back and follow it in 3 months. And radiologist C says, well, this is radiation treatment. This is an expected imaging finding. So I'm going to call this non-viable. Again, all this variability in interpretation is likely related to that persistent enhancement that we see after radiation. And so all of this basically is we need to improve our treatment response algorithm, because that's fine if we're in different silos, right? As a radiologist, you call it something, you move on to the next case. But what do our clinicians do? What are the transplant group doing? The hepatologists, they don't know how to treat the patient. Furthermore, we know from all the studies that have been published between 2017 and a couple of years ago that after non-radiation therapy, so thermal ablation TACE, if we as radiologists call something equivocal on imaging and we come back a few months later, it declares itself as viable. And this is also concordant with many radiology pathology studies. So what do I mean by that? We look at the pathology later, and if we called something equivocal on imaging, usually it is viable on pathology. After radiation, however, if we call something equivocal, meaning it's still enhancing over time, so we're following these patients up, usually that enhancement disappears and it's non-viable. So all of this basically means that we need a new algorithm to better characterize treatment response depending on the type of therapy. So what's new in version 2024? We have 2 cores now. We have a core for radiation therapy and non-radiation therapy. So we have many updates for the non-radiation based treatment response algorithm, a new algorithm, a new category, which I'm going to get into, non-progressing. We have simplified basically the whole algorithm. I don't know, I should actually have put up a picture of the old algorithm. Lots of text, lots of criteria. It's very simple now, and I'll show that in a minute. We added ancillary features and a lot of new educational content within the core with multiple examples of what is expected, what is not expected, and how to categorize lesions. So we're going to start now with the first core, which is the non-radiation core. So key concept, okay, when we think about treatment response, you really have to understand the pathophysiology in order to accurately characterize a lesion. So the concept is tumor response after non-radiation based therapy should be immediate. Whether you're doing ablation or whether you're basically cutting off the arterial supply plus or minus chemo with the C-TACE and DEB-TACE, you should get immediate tumor death. So mass-like enhancement of the lesion should disappear immediately. Therefore, if at any time after treatment of using non-radiation locoregional therapy, you have persistent enhancement, then you want to categorize that as viable. So here is the new algorithm. And really, it's very simple. You look at the tumor on imaging. So the first one, non-evaluable, basically your imaging quality is suboptimal. You can't characterize the lesion. But the next 3, do you have mass-like enhancement? Yes. Okay, it's viable. Do you have mass-like enhancement? No, it's non-viable. Do you have mass-like enhancement? No idea. I don't know what to do. I'm going to call it equivocal, and we're going to come back in 3 months and follow it up. And then there's kind of examples of what is mass-like enhancement. The other thing that this algorithm includes is kind of a management table. So if we characterize something as non-evaluable, non-viable, equivocal, or viable, what does that mean for our clinicians? What does that mean for management? We can't as a radiologist exactly say, okay, this is what should happen. But what we can say is we suggest imaging follow-up, with non-viable, with equivocal, either we can follow them up, but let's say the AFP is going up, well, then maybe we'll present them at tumor board. And then with viable, you definitely want to present them at tumor board. We don't want to say, oh, there's viable tumor, and then they come back straight to radiology for retreatment. With liver cancer, with HCC, with these transplant patients, it's critical that these patients be presented at multidisciplinary tumor board for consensus decision on management because they're very complex patients. All right, so no mass-like enhancement. What does that mean? Really, the lesion's gone. There's no enhancement. There's a smooth rim of enhancement, or there's parenchymal perfusional changes. So let's look at some examples. Now, this is a patient who underwent microwave ablation. And here on a non-contrast or pre-contrast T1 MRI, you see this hyper intense area. This is without contrast. So we know this is coagulation necrosis, which is expected after any thermal ablation. How can we confirm? Well, first of all, we know that this is non-contrast, but let's say it still looks hyper intense on your arterial phase. You could use subtraction images. If this was a CT, you'd have a non-contrast CT to show that it's hyperdense and it's not enhancing. That's coagulation necrosis. Again, that's an expected imaging feature after therapy. Here we have a smooth rim of enhancement surrounding the lesion. Again, expected, non-viable. And finally, here we have areas of parenchymal perfusional changes surrounding your tumor, your treated tumor, I should say. It's not mass-like. One trick is to look at this on your portal venous and delayed phase of imaging, and it becomes iso-enhancing. And again, this is another expected imaging feature, which is non-viable. Here we have an LR5 observation in the liver, and the patient was treated with thermal ablation. And what do we see? We see non-enhancing ablation zone, or you could get smooth perilesional enhancement. We see the treatment zone should be larger than the tumor. I didn't do this. I don't know who did this. This is way larger, but that's okay. The point is that you want it to be larger. Why do you want the treatment zone to be larger? Because of microscopic disease along the margin of the tumor that we cannot radiographically detect. And in patients with early post-treatment recurrence after thermal ablation, often it's because we didn't treat the microscopic disease. So you always want it to be larger, gradual decrease in size over time. So those are kind of expected non-viable imaging appearances. Here's one more, an LR5 observation. We have no residual enhancement of the targeted lesion with smooth perilesional rim enhancement. You have parenchymal perfusional changes, and this is where I was talking. On arterial phase, it's hyper-enhancing, and on your portal venous phase, the last image, you can see that it's now iso-enhancing. So that's a good example of this being perfusional as opposed to tumor. And then finally, the intrinsic T1 hyperintense central coagulation necrosis. Again, you want your treatment zone to be larger and then decrease in size over time. So this is all LRTR non-viable. How about this patient? So this patient had thermal ablation, presents 3 months later. And what we see here centrally, I don't know if my mouse is going to work. Right here, this is the area of coagulation necrosis. And now we see all of this enhancement on basically surrounding the tumor. So the question is this perfusional changes or is there viable tumor, right? We're kind of in that when we're reading these cases, you're confused. What do we call this? So one, although washout is not part of the treatment response algorithm, I think it's a good trick to look for. So here we have an area that's washing out. So that's definitely viable tumor. This is tubular. This ended up becoming tumor in vein. But we have this other area, which is enhancing and becoming iso-enhancing. So that is what your geographic perfusional changes are like. So I like this case because it kind of shows you what to do when you have this enhancement. What do you call viable? What do you call non-viable or expected? And if you were unsure, you could always just call it equivocal and follow it up in 3 months. All right. Moving now on to more viable examples. So mass-like enhancement, any degree, any phase within the tumor along the margin is LRTR viable. So here we've got a few examples. The first image is post-ablation. You see 2 nodular areas of persistent enhancement, and that's compatible with LRTR viable. The second case, we have our pre-TACE. This is an LR5 observation. Post-TACE, you see just a little bit of necrosis in there. The entire tumor is still really enhancing. So this is compatible with LRTR viable disease. Real quick, now using iodized oil as an imaging biomarker. I bring this in as we talk about treatment response. While this is not technically part of the LIRAD's treatment response algorithm, I think you guys do a lot of CTASE here, right? So I think this is important for you guys here specifically. So here we have an LR5 observation. The patient was treated with conventional TASE. So when you look on your non-contrast CT here, immediately post-CT cone beam, you see that there is homogeneous kind of parenchymal staining where the tumor was, but you don't see this dense tumoral staining, right? Patient comes back 1 month later, and what do you see? You see viable tumor, arterial enhancement, washout capsule. So Lopidol can actually be used as an imaging biomarker to suggest treatment response. And so I just bring that up, that if you ever see something like this, you want to see really good staining of the tumor. If you don't, then you would be suspicious that there could be viable tumor or early post-treatment recurrence. Just to give you another example, here's an LR5 observation. Here, the patient underwent conventional TASE. Non-contrast CT, you see very heterogeneous tumor staining, right? There's large areas of the tumor that are not taking up the TASE. So when we look on our post-contrast images, again, you can see there are areas of necrosis, but there's still areas of persistent enhancement, washout, and capsule. So this would be LRTR viable disease. Because remember, this is a non-radiation form of therapy, so you expect immediate devascularization. Patient underwent repeat TASE. Now we see very homogeneous staining of the tumor. And afterwards, you can see that there's no residual enhancement. And again, you can see the perfusional changes where that red or that yellow asterisk is, which becomes iso-enhancing, minimally hyper-enhancing on your portal venous and delayed phase. So now you can call this non-viable. All right, so we simplified the terminology. I gave you some examples of non-viable and viable. What about this equivocal terminology? What does that mean? How does that impact patient management? Usually when we call something equivocal, we don't want to rush to retreat them because remember, these patients are sick, they have cirrhosis, and oftentimes they have more morbidity and mortality from their underlying liver disease than from the tumor itself. And if we treat them too early, like repeat treatment, we could actually worsen their disease process. So what our study showed was that ancillary features actually really do help to identify viable tumor. So I'm going to come back to this slide in a minute. So let's talk about the role of diffusion. Diffusion is very helpful in detecting small amounts of viable tumor, particularly in the equivocal cases. Occasionally, it can be false positive if there's a lot of inflammation and hemorrhage. And studies have actually also shown that if you have an increase in your ADC values by greater than 10% after TASE, it can be a predictor of treatment response and prolonged survival. While diffusion was not included in the 2017 treatment response algorithm, remember, it is included in your diagnostic algorithm as an ancillary feature. We do know it can help with treatment response assessment. And how do we know that? Well, there are many studies. Actually, now there's 5. I only highlight 2 here. But in all of these studies, they use radiology and pathology to look at the value of ancillary features. So what do I mean by that? All these patients who are included in this study have either explant or explant or resection pathology. Someone goes back and retrospectively reviews their resection imaging, and they give it a version 2017 category. Is it non-viable, equivocal, viable? And then they say, if we add ancillary features, is there any change in our final category? And all of these studies, I'm highlighting 2 here, do show that ancillary features increases the sensitivity to detect viable disease without changing specificity. So, for example, if you look in this Park study from 2020, Reader 1 and Reader 2 had 9 and 12 equivocal categorizations. If they added diffusion or T2, that equivocal categorization went down significantly. And you can see in the Kim study, I mean, it's even more dramatic of a change. Now, all of these cases showed pathologic confirmation of viable tumor on explant and resection. So what do I mean by that? So then when they go back and they compare the pathology, if I had called something, oh, I think it's equivocal, patient went on to have transplant, the pathologist said, oh, there is viable tumor there. Okay, so but adding ancillary features now, if I called it viable pre-transplant, I'm concordant with the pathology. So because of that, and the number of studies that showed the utility of ancillary features, specifically diffusion, more so even than T2, we have added ancillary features into our treatment response algorithm. So restricted diffusion and mild to moderate T2 hyperintensity, where in the area of uncertain mass-like enhancement, and you can upgrade to viable from equivocal. Remember, if it's a new lesion outside of your treatment zone, you want to use the diagnostic algorithm. If it is a lesion treated by radiation, you want to use the radiation algorithm, which I'll get into. And if it's systemic therapy, you don't want to use LIRADS, you want to use any institutional or RECIST type approach. So let's look at this case I showed you earlier. LR5 observation, arterial, so they underwent DEB TACE. 1 month later, arterial phase MRI shows this area of enhancement, right? Is this viable, non-viable, equivocal? So, and then if you look at diffusion at that time point, you can see there's a little bit of restricted diffusion. So if we use version 2017, we would call this equivocal. However, with the addition of ancillary features, you would call this viable. This case was done pre-2024, so this was called equivocal. When the patient returned 3 months later, we see that there's an increase in the size of that abnormal area. It's viable with increasing restricted diffusion. So at this point, it's definitively viable. So you may ask, well, really, who cares between 1 month and 3 months? How does that change management? Well, maybe this patient's AFP was negligible, and so it doesn't change management. But maybe this patient's AFP was sky high, and it went, you know, it's 150 still. They're on the transplant list and we don't know what to do. And so in that case, this patient may get retreated to bridge them to transplant. So it does make a difference that we may not realize, but from a more global multidisciplinary team effort, it does make a difference for these patients. All right. I know questions are for after, but I'm going to switch to the radiation core. Are there any questions about what I've shown in the non-radiation core quickly that I can answer? No. Okay. So let's talk about radiation now. So the key concept with radiation is that cell death may not be immediate and it evolves over time because of the mechanism of action of radiation-induced cell death. So I think it's important to understand the pathophysiology of radiation-induced cell death in order to understand what treatment response is afterwards. So after radiation to a tumor, there are two pathways of cell death. There's your direct damage pathway where you have immediate double and single strand break and cell death. We see this often with our high dose Y90 patients, right? We treat a patient immediately post-treatment or on their 3-month follow-up, there's no residual enhancement. There's another pathway, the indirect damage pathway, where your cellular damage is not immediate. In this case, there's free radical and reactive oxygen species formation in the tumor microenvironment, which results in cellular senescence, which means that the cell is still alive, but they can no longer divide. And eventually, they undergo cell death. Therefore, persistent enhancement, which is a common feature that we see after radiation therapy, may be because the cells are metabolically active, but can no longer replicate, which can explain differences in post-treatment imaging after radiation as compared to our other forms of conventional locoregional therapy. So depending on the type and dose of radiation, mass-like enhancement and ancillary features which favor viability, diffusion and T2, may persist after locoregional therapy and has a different implication than what I just told you about the non-radiation treatment options. Therefore, change over time becomes very critical in this cohort of patients. Persistent mass-like enhancement after radiation therapy, which is stable in size or decrease in size over time, then is now called LRTR non-progressing. I'm going to show you a lot of examples of that. So here is the new algorithm. Non-evaluable is the same as it was for the first algorithm. No mass-like enhancement, it's still non-viable. Definite mass-like enhancement. Now, after radiation, you've got two pathways. Is that mass-like enhancement new? Is it increasing? Then it's viable. If it's stable or decreased, we're going to call it non-progressing and basically treat it like our equivocal. We're going to continue to follow up imaging. Ancillary features, I'm not going to go through this again. It's very similar to what I said previously. Diffusion restriction and mild to moderate T2 hyperintensity. But where is that area of restricted diffusion? It's in that area of stable or decreasing mass-like enhancement. Then you can upgrade from non-progressing to viable. Because oftentimes after these radiation-treated patients, we're very confused on what to do. And I already went over this, that if it's a new lesion, you want to use the diagnostic algorithm. If it's now treated, we're talking about the radiation algorithm. So if it's a treatment that was treated with non-radiation therapy, you want to use the non-radiation algorithm. And if it's systemic therapy, you're going to use your institutional or resist type approach. All right, so here we have a large lesion, LR5. 3 months after Y90, you can see complete necrosis of the tumor. You can see surrounding perfusional changes and the expected post-radiation findings. And so this is LRTR non-viable. Over time, after radiation, you can see resolution of that geographic parenchymal enhancement with atrophy of that left lobe of the liver. How about this patient? Here's an LR5 observation. What we see at 1 and 3 months is similar size. However, there's no central enhancement, and you have the smooth rim of enhancement compatible with non-viable disease. Over time, this treated tumor gets smaller. And on the earlier timeframes after radiation, you often get really extensive geographic arterial phase hyperenhancement, which eventually converts to delayed phase enhancement because it's radiation fibrosis with atrophy of the liver. Here's a patient who has a large LR5 lesion, and I'm showing you 3 time points where the patient had after Y90. And you see subsequently decreasing size and decreasing enhancement of this kind of perilesion along the periphery of this tumor. And so this would be non-progressing at every time point. So even if this is 2 years out and it's still enhancing, has areas of enhancement, as long as it's stable or decreased, we're going to use the terminology non-progressing. And you may think, who cares, non-progressing, equivocal. It really does make a difference for our hepatologists and transplant surgeons. We actually polled a big group of hepatologists, med-onc, and transplant surgeons, and radiation oncologists, and they unanimously said that using terminology like non-progressing really helps them in management. If you think about, I don't know how many of you here go to liver tumor board, but the volume of cases that we present there, every time we say something equivocal, oftentimes it comes to tumor board. But if you use the terminology non-progressing, from the clinical point of view, it's non-progressing means they're stable. We don't have to present them. There's nothing to discuss. Unless their AFP is going up, then they may bring them. So it really can, there's always a wait list for patients to be presented at tumor board, and it really helps diuresis out some of those cases. All right. LR5 observation treated with SBRT at 3 months. You can see really no change in size, and there's persistent enhancement. You almost wonder, was this treated? But you can actually see the radiation changes in the surrounding parenchyma. It's non-progressing at 3 months. And again, at 12 months, really no change. It's slightly smaller, still enhancing. So we'll continue to call it non-progressing. I should have had this slide on the prior one, but I'm going to show you all these cases, the same case that I showed you on the last slide, LR5. What if I told you now that this was TACE, okay? What I showed you before, I'm going to go back, was that this was Y90, and we call this non-progressing. So if I told you now this was at TACE, you guys raise your hands. How many of you would call this, this is non-radiation, so we're going to use our non-radiation algorithm. So your choices are viable, equivocal, and non-viable. So can I have a show of hands? How many of you would call this LRTR non-viable? How many of you would call equivocal? How many of you would call non-progressing? Okay, that was a trick question. How many of you would call viable? Good, right, because this is intra-arterial, so non-radiation therapy. There's persistent enhancement of the tumor, and so this would be considered LRTR non-viable. And basically, if this moves, still viable, still viable. I mean, we're pretending that this was not getting smaller because this was actually Y90 and not TACE. Yes, Julius?
So thank you for pointing that out. Normally we would agree, but the question that I have is it's a small arterial phase CAT scan, right? Close to vital. So unless you have a subtraction, you can't definitely say.
True.
So
of course, leave it to you to bring up some controversy, right? Yeah, you're right. In that case, if it was with Lopiodol, right? But I'm pretending this was a taste. What if this was Deb taste and there was no Lopiodol, right? Yeah, no, okay. But yeah, that's true. So you need to have your subtraction imaging to confirm that it's not hyperdense Lopiodol and it's true enhancement, right? Because if it was hyperdense pre and it's still hyperdense post and it's not changing, then you know it's probably just the Lopiodol staining. Okay. All right. Here we have an LR5 observation, and I'm going to again show you multiple time points. So this was treated with Y90. You can see excellent devascularization, although I don't know if it projects well. There's still like foci of enhancement. You can see from my cartoon images, right? There's foci of enhancement within there. So we're going to call this non-progressing. 18 months now, there's no enhancement within it. You can see capsular retraction and, you know, the volume loss that you see with radiation fibrosis. And so this is non-viable. Okay, LR5. What do we have now? This is SBRT. So we see the tumor. It's actually the same size. And we see the radiation changes surrounding the tumor in the radiation bed, the radiation where the dose was. So this is non-progressing. 12 months, again, it's getting smaller, so that's good. There's still areas of enhancement within it. We're going to call it non-progressing. Let's talk about ancillary features real quick for treatment response. So here, I'm not showing you our pre-treatment tumor, but this was a tumor treated with Y90. And you can definitely see there's areas of enhancement within this tumor, right? So we're going to call it non-progressing. The patient comes back at 6 months, and you can see they're headed in the right direction. There's decreasing enhancement, decrease in size. We're going to continue to call it non-progressing. However, at 9 months, when the patient comes back, what we see is that nodular area along where the red arrow is at the 6 months, that's the same size at 9 months, okay? But there's new restricted diffusion. So based on the optional use of ancillary features, that restricted diffusion can allow us to upgrade this from non-progressing to viable. Of course, we didn't have ancillary features when we dictated this case. They come back at 12 months. Now they have rising AFP, and you can see while the majority of that tumor is getting smaller, where the red arrow is, that area of enhancement is getting larger, and so this is now definitively viable disease. Here, pre-treatment, you see this LRM observation. This was biopsy-proven HCC. There's restricted diffusion, and there's T2-weighted signal within it as well. This patient was treated with SBRT, and 3 months post SBRT, we can see now the tumor. This case is a little confusing, and I like this because now what do we see? We see the size is the same to minimally decrease, but now there's new enhancement. So if you strictly follow the criteria, you would say, oh, there's new enhancement. Is this viable? So the one thing I want to say about SBRT, and I don't know how much, do you guys do a lot of SBRT here? No. Not too much, mostly Y90. So at U of M, we do a ton of SBRT. So it's very common after SBRT, even like for LRM lesions specifically, that they're enhancing in your first post-treatment. It's not that they're getting bigger. It's just kind of what the radiation does to the tumor. And so sometimes we will see it start enhancing afterwards. So I would, you know, at that 3 month, just be really careful about calling something like this viable. I'd rather call it non-progressing because it hasn't gotten bigger and it's actually decreased in size. You can see decreasing restricted diffusion and decreasing area of T2 signal. Okay, so those are other signs to suggest it's probably part of the treatment process. 6 months, what are we seeing? At 6 months, you're seeing this extensive radiation fibrosis in the liver, but that central area where the green arrow is non-enhancing. And there's really no residual, well, it doesn't matter if there's diffusion or T2 because it's really enhancement that we're looking at in size. So this was called non-viable. At 12 months now, look at that area of that hypo-enhancing or non-enhancing area, I should say. It's getting bigger, right? But there's no quote unquote mass-like enhancement. So what do we do here? We are seeing increasing restricted diffusion centrally. We are seeing this T2 signal. So now in this case, we could, you know, you question, do you call this viable or not? I'm just showing this case to be like how complex these tumors, you know, treatment response assessment can be. But since there's no mass-like enhancement, I'd probably just bump this back up to non-progressing because we don't know, unless AFP is going up. And then at 15 months, you can see it's larger. There now is mass-like enhancement. It doesn't matter if there's diffusion restriction or T2 because we know there's definitive mass-like enhancement that's increasing in size. And so you would call it viable at this time point. Here's another LRM observation. And after 3 months post-tear, you can see there's no enhancement, smooth peripheral rim of enhancement. It's non-viable. 9 months, similarly non-viable. Notice that there is another tumor here in segment 2 that's gotten bigger. So would I call that, how many of you would call that LRTR viable? How many of you would call that LRM? Or 5, yeah, M, because, yeah, so that's, you want to use the diagnostic algorithm, not the treatment response algorithm, because that hasn't been treated. So then we come to our 15-month treatment scan, and the other lesion has since been treated. But we're talking about this Y90 treated lesion, and you have this new nodular area of arterial phase hyperenhancement. So with or without the washout in capsule that you're seeing on the portal venous phase up there, this would be viable because you have new or increasing mass-like enhancement. Again, just to talk about ancillary features one more time, optional use of ancillary features to upgrade from non-progressing to viable. So here we have an LR5 observation. I know these are not the best images. It's really hard to find ancillary features after Y90 or SBRT. So we've got this kind of hazy geographic parenchymal enhancement, but that actual mass-like area that you see on the first image, you don't see anymore. So this was non-progressing. At 12 months post-treatment, what do we see? We see, again, that geographic arterial phase hyperenhancement, but there's new restricted diffusion here. And so at this time point, you could call this non-progressing, or if you want to use ancillary features, you can bump it up to viable. And what we saw at 15 months is there's increasing arterial phase enhancement, increasing restricted diffusion. So it's definitively viable at this time point. And almost done. I'm just really quickly going to talk to you about biologic therapies or, systemic therapy. So we know that we have multiple new therapies, systemic therapies for treatment of HCC with the checkpoint inhibitor therapy. Remember, treatment response after systemic therapy should be with mRECIST, RECIST, or any other, those type of patient level algorithms, not with LIRADs. So here we've got a patient with a large HCC treated with atezo-bev. What do we say? I don't know why that says post-nivo. It should say atezo-bev, sorry. We see no enhancement of the tumor, smooth perilesional enhancement. So that would be a complete response. Here we have a patient with a tumor, and then you see multiple enhancing foci within the left lobe. And then over time on follow-up, there's definite progression. So this is an example of progressive disease. How about this patient, BCLC, treated with atezo-bev? You can see on the top 2 images, there's multifocal tumor. On the bottom image, I have an arrow pointing to the retroperitoneum. There's really not much there on that first time point. 6 months after, you see increase in the tumor, right? Increasing tumor burden. And now you're seeing in the retroperitoneum new lymph nodes. And so this is an example of progressive disease. And at 9 months, again, you see the retroperitoneal lymphadenopathy is even getting bigger. And there's increasing burden of disease within the liver. So that's an example of progression of disease. Finally, this is a patient treated with durva-tremi with an LR5 observation. What we see over time is decreasing size, decreasing enhancement. And so that would be partial response and eventually going into complete response if you use mRECIST, because there's no enhancement. If you're using RECIST, which is size-based, then you would say it's a partial response because there's still tumor there. So in conclusion, there's an increase in HCC incidence. As we know, there's an increase in the number of local regional therapy options for treatment of HCC, which makes treatment response assessment very complex. Post-treatment imaging is essential for management of HCC on a lesion level. After radiation-based local regional therapy for HCC, arterial phase hyperenhancement is common and expected. And so the updated treatment response algorithm considers differences in post-radiation imaging findings in order to more accurately capture treatment response. Version 2024 provides this new framework to describe treatment response after local regional therapy. Remember, misinterpretation can impact clinical management. such as unnecessary additional treatments, which can actually cause more of a problem for the patient's more morbidity than having a little bit of viable tumor. Always, always, always multidisciplinary collaboration. That's very critical for this cohort of patients. Thank you.